access to monitor them at that time will be able to hear the sweet sound of my voice and whoever else speaks on this line. But I'll go away soon. It'll be pushing the audio as soon as we'll be able to hear the sweet sound of my voice.
Ah.
Yeah, so it sounds like everything's working. I'll go away soon. It'll be pushing the audio as soon as we'll be able to hear.
Ooh, all right. Thank you, guys.
Okay, so I'll mute this line now. It'll now be broadcasting whatever you guys push towards.
Los Angeles. If we can have an approval of the minutes of our March meeting. Actually, Erica, first call a roll call first, and then we'll go to the vote on the approval.
Yes, thank you. Commissioner Avila? Commissioner Estradas? Can you unmute yourself? I believe I see you there.
Lorraine, can you either wave, chat, unmute? Let's move on to the next vote next attendance, and then we'll try to get her back on.
All right. Commissioner Gavidia?
Present.
Thank you. Commissioner Grimmig? I'll move on. Commissioner Hisarick? Commissioner Kato let us know that he would be absent tonight. Commissioner Kafani?
Present.
Thank you.
John Hisarick, can you say?
Yeah, I just got on.
Wonderful, thank you.
I'm there.
Great, thank you. Commissioner Lemos? Don't see her there. Commissioner Mandel?
Present.
Commissioner Ossie? Commissioner Pack?
Here.
Thank you. Commissioner Shannon?
Present.
Thank you. Commissioner Sirota?
Present.
Thank you. And you have a quorum, Commission President.
Thank you very much. Moving on, can we get approval?
Hold on. I moved Commissioner Lemos. She was in the attendees. I moved her to the panelist.
This meeting is being recorded.
Thank you. Stephanie, can you just say that you're here for the attendance officially, please?
Present.
Thank you. Right. Moving on, can we get an approval of the minutes? Can I have a motion to approve the minutes of the March meeting, please?
I make a motion to approve the minutes. I'll second. That's Hisarick. Second.
Thank you. Erica, can you call the vote, please?
Yes, and just for clarification, the vote will be to approve the minutes. You had to be here at the last minute, so I'll just call the names of those who are actually here. And that was Commissioner Gavidia.
Yes.
Thank you. Commissioner Hisarick.
Yes.
Commissioner Kato is absent today. Commissioner Kafani.
Yes.
Commissioner Mandel.
Agreed. Thank you.
And Commissioner Shannon.
Yes.
And
yes.
Thank you. Commissioner Sirota.
Approved.
Thank you. Those minutes are approved.
Thank you. Moving on to neighborhood councils. Is there anybody from any of the neighborhood councils who's present and who wants to speak or notify anything to the commission? Seeing none, let's move to public comments. Do we have anybody in the queue for public comment?
Yes, we do.
Thank you, Marvin. Can you let them in?
Yeah. Good evening, speaker. You're on the line with the Los Angeles City Health Commission. Caller with the extension 1213. Please press *6 to unmute yourself and state your name and the agenda item you're speaking on. Again, that's *6 to unmute yourself. Let me try one more time. I'm asking you to unmute, and it's *6 to unmute. Well, I've unmuted them. That doesn't seem to be working, or they don't seem to be talking.
Okay, is there somebody else in the queue?
No, that's it.
All right, I'm going to use my discretion to close public comment, being that we've given somebody 4 minutes to attempt to ask a question. I'm sorry that they were not there or were distracted. We do welcome everybody from the public to attend our meetings. Hopefully, in the near future, we'll be in City Hall, in which case everybody's welcome to come. Temporarily, though, doing the Zoom or Google, we do welcome the entire city of Los Angeles to attend our meetings. Seeing that there's no other public comment, I'll close public comment. We'll move to agenda item number 1. It is my pleasure to invite Dr. Yuhali Anaya, who's a professor at UCLA and an expert on communication and telehealth. Dr. Anaya, we're truly honored that you would take time to join us and educate us with your wisdom. Thank you.
Thank you so much for having me. Let me share here. All right, so I am Yuhali Anaya, Dr. Anaya, an assistant professor in the Department of Family Medicine at UCLA. I'm on the core faculty for the residency program, and I have my own continuity panel at both of our clinical sites. So one is a UCLA Health Clinic, and the other is a family medicine clinic within the county system. I teach residents and medical students and see my own patients at both sites. I do some hospital medicine as well. I work closely with the Latino Policy and Politics Initiative and the Center for the Center for the Study of Latino Health and Culture, with whom I partnered for some of the work I'll reference today. My intention is to bring you my expertise and perspective regarding telehealth in vulnerable populations, including linguistically underserved populations. And my hope is to provide you some policy considerations, strategies to ensure that no population is left behind. So in order to avoid worsening health disparities among already vulnerable populations, and now that we've entered into this new era in healthcare delivery, a health equity lens should be applied to envision what telehealth is going to look like in California's future. And applying a health equity lens means acknowledging that population level factors, including the physical environment, the built, social, and policy environments, can have a greater impact on health outcomes than individual level factors. Before heading into a discussion of what the post-pandemic landscape should look like, I'll be discussing our current telehealth ecosystem, because I think before we talk about what our next steps could be, we really need to flesh out what things are currently like for folks. So while arguably initially necessary, given the overnight need to adapt in the face of the pandemic, the rapidly accepted models of telemedicine have given rise to a variety of access barriers for our disadvantaged populations, inadvertently really leaving some of our most vulnerable patients behind. So telehealth care that is equitable is readily accessible, both in person and virtually, for all individuals regardless of linguistic, literacy, or socioeconomic status. It takes into account the underlying landscape within which our patients are situated and the structural barriers that they face as a result. So far, and unsurprisingly, the literature is demonstrating the usual patterns of access disparities that favor affluent, young, non-Hispanic, white populations in telehealth, and we're leaving behind vulnerable and already underserved patients. And this is a system-level bias. Disparities in healthcare access and quality of care for minorities have been extensively documented in the literature prior to the skyrocketing and incorporation of telehealth. On average, Latinos and African Americans have worse access to effective healthcare than do non-Hispanic whites, but we're worsening these healthcare disparities if we set up or continue telehealth ecosystems such that only advantaged populations can use them. So first, the structural barriers is, of course, technology. This means not only the physical devices, but also the software that we require patients to use in order to access our portals and virtual visits. Black and Hispanic adults remain significantly less likely than whites to own a computer or have high-speed internet at home. 82% of whites report owning a desktop or laptop computer compared to 58% of blacks and 57% of Hispanics. So if the telehealth systems that we employ require virtual visits or portal access to occur via a computer and broadband, you're physically excluding a big segment of the population. Beyond having a physical device, successful telehealth use requires that patients have the prerequisite experience and skill set to use the required software. We often call that digital literacy. Despite us increasingly using online portals to theoretically increase patient access, there's consistent evidence that racial ethnic minorities, those for whom English is not their primary language, and patients with lower income and health literacy are significantly less likely to use portal websites. However, there is data demonstrating that these vulnerable populations express interest in portals, so the issue is not one of lack of interest. It really is just that we're not doing it right. Another big issue is access for limited English proficiency populations. So in California, we know nearly 44% of the population speaks a language other than English at home, and about 19% of the state population can be categorized as limited English proficient, or LEP. After English, Spanish is the most frequently spoken language in the U.S. and California, but limited English proficiency patients face systems of care that are, of course, designed around the provision of care for English-speaking patients, and telehealth systems have been no different. There was a recent study of 170 hospitals across the U.S., and only one hospital website clearly noted interpreter options for virtual visits, and most hospitals required navigation in English. Further magnifying this issue is the very limited supply of language-capable providers, and in fact, our prior research shows that Spanish-speaking physicians are the most underrepresented in the physician workforce here in California. So not only have patients been affected by the patient-level structural barriers, but also by the structural barriers that their providers face. The barriers that providers are experiencing ultimately affect patients and disadvantage patients disproportionately. So things like not having the needed hardware, which often was as simple as safety net clinics not having webcams to conduct their virtual visits. The cost of implementation to build up that equipment infrastructure. System infrastructure, so electronic health record system capacity limitations. So for example, at our county facility, our EMR does not support launching a video visit from the chart. We're still working on broadly setting up video visits for our primary care patients, and so our patients don't have the option to access visits in many cases. Existing clinic capacity, so such as not having tech support in real time that can troubleshoot during issues launching virtual visits. And of course, the cost-related barriers and adding staff to perform these has become vital tasks. And lastly, provider reimbursement issues, which I know you're all aware of is contributing to disparities in access, namely lack of consistency across payers, and especially highlighted at the onset of the pandemic, lack of payment parity. So these issues really highlight some areas that we need to focus on first before moving directly to or only to policy around reimbursement of one type of telehealth and not others. I think if we purposefully and strategically design telehealth that addresses these identified barriers, we can achieve excellent, equitable outcomes for individuals and families while using healthcare resources wisely. Let's see. So as a primary care physician, I do see how telehealth could serve as an opportunity to improve chronic care management. And if done right, improve health disparities for underserved populations by meeting those populations who need accessible care the most where they are, and that's really what equity is about. What we're seeing in practice, as well as in the literature, is that the convenience of telehealth can lead to reduced no-show rates, because patients are able to get receive the care that they actually need. Specifically, delayed care does lead to higher costs later in the form of treatment costs, specialist appointments for hospital admissions, the unnecessary complications of conditions that'll just continue to worsen over the time through which a person delays care. And this isn't a theoretical risk. It is what we see day in and day out in clinical care of vulnerable populations. You could ask any one of my trainees about this. Delay in care leads to greater pathology, morbidity, and years of heightened healthcare costs. And so, it is, sadly, it's well known that greater pathology is seen in the systems of care in which patients are forced by structural barriers to delay care. And that's something that my trainees, even, as young as my medical students, know and reflect on with me. Reduced spending by limiting access can be worthwhile considering for populations not facing existing structural and systemic barriers to care, but not in these vulnerable populations, and will most certainly not lead to reduced costs in the long term. So these patients don't need any additional barriers to care. Another value that's important to highlight is the ways in which traditional in-person visit a telehealth visit might actually surpass the effectiveness of what a traditional in-person visit might bring. We recently published a paper with some colleagues in which we found that a physician being able to do a home visit, but actually via virtual visit, was something new that we were seeing in primary care telehealth. Things like allowing for more time for counseling and education than you might find in an in-person visit. So these things can be especially valuable in the care of patients with chronic disease who are also vulnerable just from their medical conditions. And studies have also found that telemedicine visits either decrease or do not increase follow-up visits and increase treatment adherence, so thus still decreasing costs in the long term. So first we'll look at what the post-pandemic landscape should look like in the long term, and then we'll discuss some additional things that we can kind of do in the interim to get there. So to minimize overutilization, low value, and unnecessary telehealth visits, thereby controlling healthcare costs, what we can promote are integrated telehealth and discourage direct-to-consumer approaches. Integration of telehealth into existing chronic care management will allow us to provide effective, equitable care and really take advantage of those new opportunities that lie in telehealth while still controlling costs. This type of setup allows for in-person care to be supplemented by some virtual visits, and when appropriate, when necessary, phone visits, which alongside remote patient monitoring, also when clinically appropriate, can together bring telehealth's promise in providing better, more effective, and efficient care to fruition. To give you an example of how this might work. So let's say we have a patient, Mr. C, he's got very poorly controlled diabetes. Why do we care about his poorly controlled diabetes? Because it's setting him up for the long-term microvascular complications that lead to things like split amputations, for example. So this is a patient that right now you'd be seeing on a monthly basis because of that poorly controlled A1C. Your patient is here for their visit, they're due for their foot exam, you perform that. In a system that allows them to access telehealth, you set them up for a video visit the next time. The patient then will send you their blood glucose log for review before the visit. And in a virtual visit, you can review that in detail, adjust their insulin, etc. But let's say the patient doesn't have that needed internet speed because of cost. And so despite, we'll say you have an excellent and patient-centered video visit app, despite that you can't actually launch that virtual visit. So in this case, you're forced to call them on the phone. You achieve the same care you would by video. You titrate their insulin, you place the referral for the retinal exam. You send their new insulin prescription to the pharmacy, and that all takes the same amount of time, incorporated the same work that it would have taken in person, and as such, it has replaced an in-person follow-up visit. And the next visit, let's say you see them in person, and so on and so forth. And this is a system that works, and it's cost-saving in the long term, and that's why systems have continued doing it over the years. Integrated systems like Kaiser, for example. All right, so to avoid disenfranchising underserved and vulnerable populations, the core components of a telehealth ecosystem infrastructure that we can pursue are first and foremost inclusive technology. So rather than expect patients to adapt to our suboptimal systems of telehealth care, we can improve our delivery systems to meet their tech capacity. And then we can work to actually improve our patients' capacity. Next, ensuring equitable access to the necessary technology and broadband without which they can't complete video visits. Tech support, who can walk patients through signing up for portals and virtual visit apps and help them troubleshoot in real time. And requiring payment parity for equal care so that providers really provide the care that patients in a safety net need. So some policy considerations. Having a vision of equity in telehealth means taking into account both our patient consumer base, for example, thinking about the languages our softwares and our software and platforms are provided in, meeting the language needs of limited English proficiency patients at all points of contact is required by various statutes. We also have to take into account our provider base, who is caring for these populations day in and day out, and what are they still missing to ensure virtual visit access for their patients is continued? Is it technology? Is it equipment? Maybe reimbursement for that, tech support for patients that we were discussing. And then finally, acknowledging the reality that video visits at home may not be an option for some patients for whom it is necessary, even in the long term. So long-term payment parity for virtual visits in which the same service is provided as in-person care does matter. Payment can then be applied to the associated costs that come with telehealth delivery to the underserved populations that currently telehealth has disenfranchised. Specifically, the dedicated tech support we've discussed, patient-centered education and digital literacy, patient-friendly platforms. Within the discussion of payment parity, what we can also think about is that work as a physician, the work on your end, the expertise you're applying, it's equal whether your patient is in front of you or on video. And in cases for patients that have limited health or digital literacy, your job is actually even harder via telehealth. Additionally, in primary care at least, patients are still being roomed by ancillary staff even if they're on a virtual call. Staff continue to check patients in and follow up with patients after their visits, whether to give after visit instructions or sometimes for insurance review, billing procedures. And these visits take place in patient rooms, other clinical spaces, which means there's still that same overhead cost. In the current landscape, and until we fully transition systems at large to a value-based payment system, payment parity is needed to ensure that these virtual visits are able to be offered in our schedules for all our patients, and particularly for those that are already suffering ample barriers to care. But payment parity should really allow for contract negotiations. In other words, payment rates should continue to be negotiated. And as we've touched on, supporting alternative telehealth options when video capacity is not an option. That does require coverage of phone visits across payers and equitable reimbursement for these. Equitable reimbursement means a health insurer compensates the healthcare provider at a fair payment rate that is also taking into consideration those ongoing costs that we were talking about. So to assure equitable access across payers, including Medi-Cal, we can standardize the approach to coverage and reimbursement. We can require same benefits, require the same utilization review procedures that apply to telehealth, as to in-person encounters for each payer. So what about in the interim? Right now, we really have to focus on building up that inclusive telehealth ecosystem. Since we have not yet reached the point where patients and providers have the necessary infrastructure to immediately do away with phone visits in our underserved settings, especially amid the ongoing pandemic, we've got to continue to support payment parity for telehealth, for telephone audio-only visits in which the exact same service is provided over the phone that would have been provided in person. If the same expertise, assessment, diagnosis, and management plan is provided, a service can be reimbursed under that same medical complexity and time-based billing rules that are currently in effect. To support the expansion of telehealth services, we can also fund primary care infrastructure that's required to be user-friendly, that provides multilingual support. This is also similar for specialties. So, for example, in the primary care setting, if the telehealth platform contracts with a clinic caring for the safety net, they could be required to provide multilingual support at all points of contact in order to deliver that equitable access. And this includes the websites, the apps that our patients have to use to access telehealth. Maintaining quality and ensuring outcomes will need to be a long-term process. And making inequities visible and identifying avenues for solutions is going to require ongoing research and applying the evidence in our policy. In addition to assessing the healthcare system costs and savings that telehealth brings, we will need to assess our telehealth systems on measures of equitable access, including our reimbursement structures. We'll need to employ a systematic approach to measuring, reporting, and improving quality. And of course, we need to minimize inappropriate utilization. We can promote safeguards to ensure quality of care standards apply, whether care is provided virtually or in person, but these standards really should be developed in collaboration with physicians and active clinical practice to ensure that they're not only effective but applicable in a day-to-day clinical practice. As really no language assistant service can bridge the linguistic and cultural gaps that limited English proficiency populations face in their encounters, we'll need to wholeheartedly really commit to building up a language-capable workforce. And so, in closing, as we deploy policy around telehealth service use, we can help address and carefully avoid further contributing to inequities within this new era that we're living in, this new era of healthcare delivery, by requiring that our delivery systems are inclusive of the very populations that they're intended to serve. And that's where regulatory policy can promote high value and effective care that will ultimately drive down costs. Some references, some acknowledgments, of course, and that's it.
Thank you for that wonderful presentation. We're going to have questions from the commissioners, noting a couple things. One is for the city clerk that Vice President Grimmig joined us, I believe, at 20 minutes after 6 o'clock. I don't see him there. Maybe it's a phone call, but I was told he joined us.
I'm on if you can hear me.
We hear you. Great. Thanks, Matt. So just for the record, for the city clerk, he is here. Joined about 20 minutes after 6. And I don't see a chat area on this Zoom. So we're going to have to kind of do it old school. You can raise your hand on the participant section, and I'll be able to see that and then know who wants to ask questions. But I'll take the privilege of the chair and ask a bunch, if you don't mind, Dr. Anaya. First is, for a large percentage of population, unfortunately, is hearing impaired. That's quite significant impact. Are there studies on the use of telehealth, either visual Zoom or just straight telephone with people who are hearing impaired? And when you're talking about the indigent population who's also hearing impaired, do they have the capability of having augmented telephonic capabilities?
Yeah, so about the research aspect, I'm uncertain about, but we are able to apply interpreter services, including ASL interpreting services, through telehealth, and it does, again, kind of bear that integration that we have to think about, right? And so, even whether it's limited English proficiency, sometimes that is an additional burden that is brought into that physician interaction. And so, with ASL services, sometimes that actually has to be planned ahead, with a patient. And so, really thinking about how we can integrate these services into into our system so that it is not creating any burden for either the patient or the provider, so that we are really providing these services and each and every encounter in which they're needed.
And I also imagine that you probably have to be cautious about HIPAA violations if you have an outside vendor who's potentially going to be involved in that as well.
Yeah.
Another question is just in logistics. I know in primary care, a significant percentage of patients are no-shows or late, whatever the case might be. If you're doing telehealth, I'm assuming you have a pretty rigorous schedule for, I don't know, 15, 20, 30 minutes, whatever it's going to be scheduled. And though the practitioner could be sitting at a desk, that they could do something else if somebody no-shows. If you have a pretty tight schedule, how do you guarantee that you don't have too many people in the queue and that you don't keep people waiting so they get frustrated?
Yeah, so this is done in different ways in different practices. As an example, one way is that if you, based upon the practice, the kind of clinical practices and flow preferences of a given office, often the telehealth appointments can be shifted either to the beginning of the day, beginning of the morning, let's say, or a mid-morning or end of the day, kind of wherever fits with that particular practice. For example, in our county clinic, we're kind of advocating to move some of those phone visit slots to the beginning, because sometimes, and especially now, as you can imagine, with registration and checking in now taking longer with temperature checks and lines outside of the building to get in, patients are now registering a little bit late. By the time that they're being roomed, right, the entire 20-minute visit has already passed. And so thinking about actually transitioning some of those phone visits, video visits to the earlier, so that the provider has started those visits. In the meantime, patients are getting physically roomed, vitals, all of that, and so they're ready to be seen at the end of a particular provider's phone visits or video visits. Other ways are actually they create kind of like a waiting room of sorts, and this is kind of where that ancillary staff can be very helpful in making sure that the patient doesn't log off also happens, that they've logged on time, and then accident or perhaps they lost patients, they kind of log off, and so having them in a waiting room where somebody is kind of checking in on them can be helpful. So there's a variety of ways to do it. The most practical really has been just kind of adjusting a clinic schedule to what seems to work with the flow of that particular clinic and practice.
Wonderful. And the last one is for people or for indigent populations that don't have either good internet or alternatively don't have good technology. Has anybody done a pilot study where you actually give them low-cost telephones with good video capability with either Wi-Fi or with just a direct link to whatever phone carrier? Because it might be more cost-effective to do that than to have somebody either come to the office or lose half a day of work driving to UCLA.
Absolutely, yeah. So that is, one of the things that thinking about how we can almost like bring the visit to the patient, right? So similar to how we supplement, for example, transportation costs or the actual transportation for patients that are unable to come to visits, right? We provide that non-medical transport. We can think about this in a very similar way. And somebody that actually a system that has done this, because it's another system that has done telehealth for years preceding the pandemic, is the VA system. And there have been studies in which they provide a device, whether it usually hasn't been a phone, it's actually been an iPad, and they provide these iPads to the patients in order to improve their access. And, of course, the positivity, the responses have been very positive about their ability to access their physicians that, previously they were having to drive 2 hours to or whatnot, because for a lot of these patients, it's not even just like the drive down the 405, right? right? Some of these patients are even located more remotely and need to come in to see their specialist from long ways. And so definitely something that has been done. I heard it was giving a presentation, and in one state they were actually doing distributing. And in this case, it was really just flip phones to a population of homeless patients experiencing homelessness, and that was giving them phone visit access for those folks. And so, it can very much be as simple as that, and as wonderful as providing an iPad, for example.
Fantastic. Thank you very much. Commissioner Kalfani, you have a couple questions.
I do, but actually, Commissioner Shannon had actually raised her hand before me.
All right, then Commissioner Shannon.
Hi, thank you so much for this presentation. So I had a question about the unhoused community, which was partially answered just by you saying that they were given flip phones. Mm-hmm. But I'm wondering for two things. Have there been sort of pilot studies where telehealth has been utilized with the unhoused population? And in line with that, do people need to actually come for their first visit in person, and then it becomes subsequent visits where they need to be, where they can be on the phone or, in front of a smartphone? Or could it just be like all telehealth? And the reason that I'm asking this question is I'm just thinking about people who are on the street who have their things and they won't leave their, their property unattended because they're afraid that they're going to get, that it's going to get stolen. And so this seems like, a great model for someone who may have something that, could be.
Oh, I think we lost your sound.
For the phone.
I think we lost your sound right at the end of that.
Oh, I'm sorry. Yeah, this seems like a good alternative for somebody who just won't leave their stuff that's sort of like on the street, where you could maybe provide some guidance to someone. So if you could sort of explain what that looks like, if you've encountered that or if you know of any studies.
Yeah, absolutely. So that is an excellent point, and we encounter that even like in the hospital, right? Patients don't want to come in and be hospitalized because they don't want to leave their stuff. They don't want for it to get picked up and stolen, and so a very real issue that patients face. What has kind of, this actually relates to some of the policy proposals and changes that were made. So traditionally, it has not been allowed for that first visit for new patients to have access to telehealth, only for established patients in a given practice. So if a patient is already an established patient, then they were allowed to be able to transition into their telehealth visits with no problem. However, there have been restrictions around that, and I guess I can understand some of that, but for example, in these cases, it would kind of behoove us to allow to expand, at least in certain scenarios, if we are worried about the unintended consequences about doing kind of like a blanket change like that, but definitely being able to improve that access, because you're right, some patients may not want to access care if it means that they leave their things. We also, and I, will be the first to admit, sometimes a telehealth visit is not sufficient, right? It's not. And so being mindful of that and kind of creating a safe telehealth system also means that we as providers need to acknowledge the limitations of telehealth when necessary, and convince our patients to be seen in person. A phone visit can be equivalent to a video visit, can be equivalent to an in-person visit, but not for anything and everything. and ensuring that we don't actually provide inferior care to our populations, our vulnerable populations, is something that we need to consider as we're making all these decisions. So let's increase access, but be mindful of the way that we do that, so that while for some things like mental health, access via telehealth only is fantastic, and has been done in multiple studies, demonstrated that it is equivalent. Perhaps there may be other specialties that it might not be perfect for exclusive telehealth, right? And so just kind of navigating that is going to be really key as well.
Great, thank you.
Thank you.
Commissioner Calvani.
Great, thank you. Thank you for the presentation. Good information. Been trying to follow and watch what's happening with telehealth, and realizing the value and benefits on the provider side, as well as even for the consumer, but also realizing we will continue to have to address the digital divide. And because even in some areas, even if you are able to provide a flip phone or something, it still doesn't solve the problem. So I appreciate the kind of short and long-term considerations. But your data also felt very general primary care focused, and with chronic disease and specialties related to general practice. Did it also include anything related to sexual and reproductive health, or so whether it's family planning visits or STD? So I know there's been kind of a struggle during this time to really think about those visits as it relates to telehealth, and wasn't as much as an uptick as we perhaps thought it could be. So just curious, in your research, did that aspect come into it? Is there any other long-term or short-term considerations in those types of visits that should also be considered?
Yeah, thank you for the question. So not in my particular research, but I've actually been in contact with a health system, a smaller health system that provides almost exclusively reproductive care, mostly just care to younger but underserved population. And, for them, because the population has generally been younger, it has actually proved quite effective, because the patients just find it so convenient, and they're used to being on their phones, they're used to having their access to most things digitally, and so it's actually worked out quite nicely for that particular population. Thinking through things like if you would otherwise be doing say a urinalysis, right, and drawing some labs to rule out an STI, for example, and thinking about kind of how you're going to plan that, right? And so there is a little bit more of that you have to consider. So realizing that your patient may not be able to get the lab the same day, but maybe you create a system in which they can come directly to the lab, right? So we aren't creating any additional visits, but very much just trying to cater to the convenience, because it can very much increase that ability to access in a way that, like I said, this population tends to really uptake, because that's just how they're consuming a lot of information anyhow.
Thank you. And I guess that also makes sense, because it also addresses some of the confidentiality issues that you may have more in person. But thank you for that.
Mm-hmm. Mm-hmm.
I think I'm next.
You're up, John.
Thank you. All right. Thank you, Dr. Anaya, for the presentation. Just research aside, have you been able to develop in your own practice good communications with a range of clients, with a range of patients, particularly seniors?
Yeah. So it's definitely a developing actually area of research and even teaching, right? Thinking about how do we actually provide care that a patient is able to feel our presence as a clinician in a way that we used to have at the bedside, right? So that shared space, sometimes the being able to put your hand on somebody's knee when they're having a hard time, things like where your camera is situated and being able to have eye contact and not looking, down at the keyboard. And so there are definitely things that can be done to improve that experience for the patient, and things that we're going to have to be teaching our trainees as this is kind of the new normal in most of our schedules, thinking about how to do that well. We have, for example, like in my own practice, I have actually a variety of ages. So being family medicine, I do see everything from kids to a geriatric population, pregnant population, and I can tell you that really for all of those patients except one patient who does not have a video visit, and I'm talking about the UCLA system because they're not kind of experiencing some of those barriers that I was talking about. And so, but really all except one of those patients, they've been able to uptake these virtual visits. And
froze up there.
Oh, are you able to hear me? Yeah. So they've been able to uptake the telehealth care and have preferred it, actually. They felt safer, not needing to come in to every clinic visit, right? Feeling safer doing it from home, sometimes not needing to travel. And so for folks, it's been a lot more convenient, and even regardless of age, like I said, even in my own practice, I've really only seen in one case that it has not been something that they've been able to do, and so we do phone visits in those cases. But it does more often require an in-person visit for a follow-up than with a video visit. But there are definitely cases where patients take their calls from work or wherever they're from, and sometimes a family member is present there. That's also been very helpful, where family members can be present even for end-of-life discussions, where you may not traditionally have extended family or additional caregivers in the visit. Now we're doing it from home, and so you're able to meet their family members and kind of have some of those discussions that are better had as a family. I'm so sorry?
Thank you. Yeah, it cut out a little bit there, but yeah, thank you.
Any other questions, John?
No, thank you.
Commissioner Gavita.
Dr. Anaya, thank you for your presentation. In terms of utilization, do you have any data that shows trends of which types of telehealth visits are conducted most? For example, like behavioral health or dental or what have you? Especially, I'm curious, especially during the pandemic.
Yeah, let me see if I do have a prior slide on this. Let me see if I can pull it up. So traditionally, I will say that some of the kind of existing no, it's not this one. The existing literature demonstrated a lot of uptake in mental health, telehealth. It has been something that has been in practice for a long time, and actually some providers feel is maybe even more effective than in person. And this is even kind of to the point that some patients feel less barriers in terms of communicating something that is traditionally maybe taboo to talk about, maybe like sexual erectile dysfunction, for example. They're more comfortable doing it over a screen than doing it in person. And so finding that actually in certain cases, even with your patients that you've known for years, things come up in your telehealth visits that maybe would not have come up. And so similarly in mental health, there seems to be a more aptitude to be able to be a little bit more open. So that's been a really common area. There have been everything from neurology telehealth and doing things that I'm surprised as to how you might be able to have an effective neuro exam. As medical students, that was kind of like the longest physical exam that you had to learn, and so but being able to do that in a telehealth way, and other common things have been things like ophthalmology, so not so much so having a visit necessarily, but providing remote care where you are reviewing, for example, retinal camera screens. So in diabetes, we have a retinal camera exam that is supposed to be an annual exam looking for complications. And so where your patient is receiving that kind of retinal camera in their clinic, but then a remotely located ophthalmologist is reading those and providing those recommendations. And that's, again, also something that has been done for many years. So there's lots of specialties that it's been very common practice. And actually, family medicine, primary care, internal medicine had been one of the slower uptakes. And it was really because of the pandemic that we really had no other choice. And I think people have been very pleasantly surprised as to what we can do and how we can actually improve the care that we've been providing previously.
Thank you for that. I have a follow-up question. In terms of payment parity, I was wondering if maybe you could share some thoughts as to the differences there are between, telehealth payment structure and availability for, say, a privately insured patient or, employer-sponsored, health plan patient versus a Medi-Cal or a more like the safety net. What are there any disparities? Or are there any gaps? Like how can, and if there are, like how do you feel that we can work towards getting to a more equitable space in terms of telehealth?
Yeah, so that's a really excellent question. It's been something that, so the pandemic kind of allowed states to really explore that, right? And, previously California actually was one of the leaders in telehealth policy and payment. And, with the pandemic, we were able to expand that even more so. Being that commercial payers often follow what Medicare does, what Medicare is willing to do, and so realizing that it has to also kind of be something that comes, from that kind of federal standpoint, right? For Medi-Cal populations specifically, currently there are some proposals that are being looked at around payment, and some of that actually does include removing payment parity for phone visits, with the belief that phone visits are not equivalent to a video visit, to an in-person visit. It kind of has fallen into a category that is separate and different. And so, in terms of really not trying to worsen the disparities, until we really get to that point where we've set up the infrastructure such that perhaps we are providing iPads to our patients that don't otherwise have access, or that we've set up our broadband infrastructure such that there are not patients that don't have access to broadband. Really, until we get to that point, and while we're facing the pandemic, while we're in that kind of flux, it is going to be, more and more. It is going to be so important that we do still provide access to phone visits, and in a big way that does mean payment parity, at least in the interim, and perhaps not for the long term. But the way that you can kind of work around that is really the time. Application of time limits that you use for your visit. So if you have a 15-minute visit, then you're being paid for that 15-minute care that you're providing. And so that has been kind of one thing that is really currently on the table. There is also AB 32, which does promote payment parity, and so there's lots of folks advocating for AB 32 so that the payment parity continues, and that it's not that Medi-Cal has a completely different system than commercial payers, and therefore, again, you're kind of creating by design, right? You're by design creating inequitable systems of care and really just kind of continuing to contribute to that system level bias that already exists.
Thank you for that explanation. Appreciate it.
Yeah.
Any other commissioners have a question? Not seeing any. Just two statements. One following up on the retinal scans that you were talking about for the diabetics. There's actually some ongoing research using just smartphones that can, with a software package that can be easily downloaded by diabetics, be used so you don't even have to get the retinal camera.
Wow.
And which is going to be really interesting if they can get that up and operational, because that would make it really easy for your patients. The patients don't have to go to a place where there is a retinal camera. And the other issue is in regards to some counties or cities. LA County, 50% of the population has Medi-Cal. It's different in other parts of the state. Clearly, it's a bigger issue here, but Medi-Cal is one of the poorer payers. And so if you look at Medi-Cal versus Medicaid nationwide, of the 51 Medicaid systems that are in America, the 50 states plus the District of Columbia having its own, we're number 49 out of 51 near the bottom for payers, which is problematic if you want to have high quality access. And we know that unfortunately subspecialists are limited in the networks in the Medi-Cal system. And so it's even harder. So for as a primary care person who might be in the Medicare system, a Medicaid system, it's hard for you to get consultations with individuals who accept it. There might be an area with high cost of running a practice. In other areas that are lower cost, it might be easy for people like yourself as a family practitioner to be doing telehealth at the same time with a subspecialist who is in rural California, where the rent is much cheaper and you can get the consultation in real time with your patient there, and have you doing all the follow-up and laboratory testing in coordination with a specialist who's just giving you their knowledge and wisdom. So, I mean, potential if we're going to be flexible. I mean, my advocacy for this would be to have the state of California increase what it pays, the Medi-Cal system, so we can get more specialists into the system and not be number 49, but maybe be in parity average for the United States, in which case there'd be a lot more access for the indigent. But for some reason, they don't necessarily listen to me and or this commission when we give advice like that. But so thank you very much for educating us. We really totally appreciate it. You're welcome to stay on to listen to our next wonderful speaker, though we also realize you're very busy and you wear multiple hats at UCLA, and so that we will not take it personally if you prefer to sign off. But we're very, very thankful that you would offer your education, knowledge, and experience with this commission, but also all the people of the city of Los Angeles. We're deeply in your debt. Thank you very much.
I appreciate that. Thank you again so much. It was an honor and a pleasure, really, to be here with you all.
Thank you. Moving on to agenda item number 2, it's my pleasure to invite Dr. Richard Berwick, who's an associate professor at Cedars-Sinai Medical Center, a obstetrician gynecologist, a subspecialist in maternal fetal medicine, one of the leading national experts in hypertensive disease with severe features, including HELP syndrome. But he's going to talk to us today about COVID, as well as testing on pregnant women, pharmaceuticals, and or vaccination. I believe, Dr. Berwick, we're honored that you would join us today.
Thank you. Let me open up my screen here. Okay, perfect. Okay. So yeah, thank you, Dr. Mandel, for having me here today, and thank you to the commission, for your time. And like Dr. Mandel said, I'm a maternal fetal medicine specialist, full-time clinician in the academic practice at Cedars-Sinai. So I work with fellows and trainees, and I have a long-standing interest in clinical translational research. Started with preeclampsia and HELLP syndrome, and really wanted to study therapeutics and try therapeutics in preeclampsia. And then, like a lot of people, when COVID started affecting everybody, and we saw a lot of pregnant women getting sick, it kind of naturally led itself into, well, what can we do with therapeutics for COVID? And then we began to see this problem, which became more of an issue of why weren't pregnant women being included in clinical trials? And it's really got magnified by COVID. So, I want to talk about inclusion of pregnant women in research, and then use COVID really as a case study to say, how does, what goes wrong, with this process, and what impact does it have? So really just, it's going to be a relatively brief skim through it, but, just get a broad sense of the scope. What does it mean, like, when pregnant women, given informed consent? Why can they or can't they give informed consent? And then COVID, what was the impact it had in pregnancy? Then what happened with therapeutic trials, pregnant versus non-pregnant? And then what happened with the vaccine, pregnant versus non-pregnant? And then what were the potential harms, that may have occurred by exclusion of pregnant women? So, what is the scope of the problem? Well, just to start, there's 6 million pregnancies in the United States every year. So that's a lot. That's a lot of potential women that may be affected. But it's bigger than that because there's a lot of factors around pregnancy. We think of postpartum and then breastfeeding, right? And then what about those planning to conceive, right? They're in that process of building their family. And then also reproductive age women, because we know half of pregnancies are unplanned. So really, the impact is actually much broader, and the amount of women that are affected by these exclusions really starts to increase. So why are pregnant women excluded? And so I want to talk about, immediately most people think of, right, the risk to the baby, which is true. As an OBGYN, we're worried about birth defects for the baby. So this medication, if it's a new medication, new therapeutic, it may cross the placenta, may have negative effects for baby. Also worried about, could it lead to miscarriage? And those are valid concerns. But the question is, pregnant women are also labeled as a vulnerable population. Now, for research purposes, what is a vulnerable population? This usually applies to populations that have impaired ability to make informed consent. So small children, adults with really impaired cognitive ability. For them to provide informed consent for a research trial may be challenging. There may be some concerns there. But there's nothing about pregnancy that renders a pregnant woman incapable of offering informed consent, right? She should still be able to make these decisions. So when pregnant women are labeled a vulnerable population and they're excluded, they're basically, the choice is being made for them. The decision has been made. The choice is taken out of their hands and is decided, from the very beginning. So just to, we're going to focus on COVID as a case study, and just to point out, this was most magnified by the vaccine trial data, right? So before I delve into it a little further, just to point out that vaccine trials, I showed you that big circle, right? Vaccine trials not only excluded pregnant women, they excluded anybody who could become pregnant or who was actively breastfeeding. So this is an example of the exclusion criteria. It was true for both of the mRNA vaccine studies with Pfizer and Moderna were pretty similar. Not only did you couldn't enroll in the vaccine study if you had to have a negative pregnancy test. In addition, you had to have contraception or abstain from activities that may result in pregnancy for 1 month before the first dose. Or you also have to agree to adequate contraception for 3 months after the second dose. Then you have to not be breastfeeding. So you see how that group expands. So many women are excluded by these criteria right from the get-go of these studies. So what happened, with COVID? Well, we know it became a global pandemic by March of last year, over a year ago. We know it affected adults, older adults, and it affected pregnant women. Pregnant women were not spared. And by April, we had over 2 million cases and 175,000 deaths. That was April of last year. Now those numbers look small. But we knew right away this was a lethal, life-threatening condition, right? Very, very serious. So right away, globally, doctors, researchers, all it was amazing, right, to see from a global perspective, all the scientists developed all this research at the same time. And by April of 2020, there were over 350 registered interventional trials, treatment trials, and these were open primarily to non-pregnant adults. And by May 2020, pretty quickly, within 5 months, we started to get drugs that were showing benefit. So remdesivir was the first one that showed benefit. So by May 2020, we had a treatment that had some benefit for non-pregnant adults. But what happened to the pregnant women, right? They were here. They were involved in the caseload. They were getting more sick. There were deaths in pregnant women, but they were excluded from this part. So they were not provided the intervention trials. Now you may be able to find like a couple, like vitamin D study or maybe a hydroxychloroquine study that you could find. But there were very few, and most of the meaningful large-scale clinical trials almost universally excluded pregnant women. So then when you get a drug approval, you have zero data on pregnancy, right? And I just showed you that not only the vaccine trials, but a lot of these others made sure that there was no data on pregnant women because they excluded anyone with a chance of pregnancy. So we end up with very little data 5 months into the pandemic. So, the largest of the trials was the remdesivir trial. That's just I think that's probably the best example. This was launched right away, and this wasn't just a pharmaceutical trial. It was like Gilead, it makes the drug, but they partnered with the NIH together to launch in a very ambitious multi-center RCT trial, right? Again, in non-pregnant adults. And by May, New England Journal publication showing benefit. But what was happening to pregnant women during that time? Like I said, they were being affected, and the CDC was gathering data. So if you take that 6-month time period, what we see is that 21% of cases reported to the CDC of COVID were in reproductive age women, 9% were pregnant, and they were getting sick, hospitalized, ICU admission, mechanical ventilation. So 6 months into the pandemic, we know that pregnant women are heavily affected and getting more sick, and at this point, we have no data on how to treat them. So 6 months into the pandemic is very concerning that we have very little data on how to treat them. So what do? This was my experience as a maternal-fetal medicine physician. Patients were coming in. Cedars-Sinai is a very high volume obstetric floor. We see a lot of pregnant patients. So let's take a 34-year-old pregnant, 28 weeks, 3rd trimester. She has all the classic symptoms: fever, she's short of breath, we confirm the virus, she has a pneumonia on chest x-ray, and she's requiring oxygen. And this is right how it happens, very sick. What do? Well, if she was a non-pregnant adult, you would have a number of clinical trials. And this was true at my institution, and not every institution had clinical trials, right? But a lot of tertiary care centers, academic institutions, had multiple trials for non-pregnant adults, right? The problem was pregnancy was an exclusion for almost all of them. So not just remdesivir, but there were others, right? Steroids, we had some of these cytokine inhibitors like IL-6 inhibitors. They were all, the main exclusion was pregnancy. So when I have this kind of patient come to my labor floor or a medicine floor, we can't enroll them in a trial, and we have no data on drugs. It's a really, really difficult situation. So it's not too surprising that premature delivery was very common. We see that COVID and pregnancy was linked to premature delivery because what other options did we have? We didn't really have options, but we knew if we delivered, we might be able to make the patient better because we didn't have the same options of treatments. So not only did it lead to moms getting more sick, it led to premature babies. And that's something that's not really discussed very much, but it led to premature babies that maybe potentially, if we had these same options for treatment, that we could decrease that rate a little bit. So what did someone like me and others do for pregnant women with severe COVID? Well, this is what we do for other medical conditions, and this is not unique to COVID, right? Dr. Mandel probably knows. We don't have good studies for pregnant women. We either, go based off of data in other populations. So we have to use things off-label or compassionate use. So off-label just means, here's a drug that's FDA approved for some other condition, and we want to repurpose it for, here, in this case, COVID. Now, this was very common with COVID because we wanted drugs that were readily available with some safety data. So the most famous of all was hydroxychloroquine, right? Now, that was problematic for multiple reasons because of misinformation, but it was quick and easy to give, right? So, you had all these fancy trials of drugs that were really hopeful, but pregnant women weren't offered those trials, so they were maybe offered hydroxychloroquine, even though the data was really not good, right? We really, as most physicians who interpreted the data knew that there really wasn't much there with hydroxychloroquine, but it was the only thing that we had to offer. And then there's no safety monitoring, there's no data collection. When you give it off-label, you're giving it, and there's no real formal process of evaluation. So much different than a clinical trial. But what about compassionate use? Compassionate use is okay, you have a drug that's not as easy to give, right? Hydroxychloroquine is a drug that most doctors can just give. It's pretty cheap. You can get it pretty easily. But a drug like remdesivir is restricted access. It's maybe expensive. And, how do you do that? Because when I started seeing pregnant women come in, we had adults being enrolled into the remdesivir trial at Cedars-Sinai. And actually, Cedars-Sinai authors actually were publishing those, authors on those New England Journal trials. And so I could see firsthand in my own institution, these potential benefits. And I said, why can't I get this for pregnant women? Well, it turns out you can get it for compassionate use, but it's a long, tedious process. So you have to request it from the company. You have to file an emergency application to use it with the FDA, and then you have to appeal to your internal IRB. Most of those people actually will end up agreeing to it as long as the patient meets the criteria. But who's doing this paperwork? It's us, the physician, and no one tells you how to do this paperwork. It's complex. There's tons of forms to fill out, and the process takes 2 to 3 days because even once they approve it, they then have to ship you the drug, right? So this is how pregnant women are treated, right? And what we know with COVID, and we didn't know this the whole time, but there is a critical 2 to 3 day window. When someone's admitted with severe COVID, it becomes critical and life-threatening within 48 hours. Within 2 to 3 days, you might be in the ICU and intubated. So you have to intervene quickly, and most of the data shows that if you intervene quickly, you can dramatically improve the outcomes. But you can't treat pregnant women quickly because of this long 2 to 3 day process, right? So by the time you get the drug, and what happened, I actually worked with Gilead to publish the remdesivir data in pregnancy, is we found exactly that. The doctor ordered remdesivir through this process. By the time they got it, the patient was either delivered or in the ICU. And so you see that this process is helpful. I was definitely thankful to have this, but it wasn't an optimal approach. So, how does this kind of snowball? This effect kind of snowballs because you have non-pregnant adults. They're enrolled in clinical trials. Great, perfect, exactly what we want, right? This is what we call level 1 data, randomized controlled trial. One group gets a drug, the other group gets placebo, no drug. And you can actually know if it's safe and effective. So great, we did that, like say in the case of remdesivir. It's effective. It's not a game changer, right? We know that there's some critiques of it, but it definitely seemed to shorten the disease course. It's FDA approved, which is great. This is what we're hoping for, the first breakthrough that we have for COVID. And then immediately say, great, let's give it to pregnant women. Well, guess what happens? Can we? we have no data, right? So we finally get to the point that we want an FDA-approved drug, and we have no idea if it's safe in pregnancy. So we're 6 months into the pandemic. We have a drug that works in non-pregnant adults. We don't know if it's safe or efficacious in pregnant women. What about the fetus? What about breast milk? We don't know. So, and how are we going to get this information? So you see this sort of chain of events. And we know, non-pregnant versus pregnant, there's dramatic differences, right? It's not just the baby. The baby is obviously a major, major concern, but drugs are metabolized differently. There's a different volume of distribution. The dose might need to be different. So, there's multiple layers, and there's no reason that they should be excluded. So we get stuck in this sort of revolving circle. So this dilemma, which I call the pregnancy dilemma, which is true for most about every drug. One, women are excluded from the trials. So, okay, pregnant women wait patiently until the trials are done in non-pregnant adults. And they wait, and their reward for waiting is that even when a drug is approved, people question it because of lack of data. Not only the physicians, right? The patient. Because what is the first thing that the patient asks me as a physician? Is it safe? And I really can't tell them. I can give them data from what I see in non-pregnant adults. So as a physician, I have to tell the patient that I just don't know, right? And then a lot of pregnant patients with COVID were managed by infectious disease doctors, critical care doctors. They have a lot less experience with pregnancy. They really, it's difficult for them to counsel on the finer points, right? So obviously a key is getting OBGYN and maternal fetal medicine involved in these discussions. But what happened in many cases, in many hospitals, the infectious disease doctor or the critical care doctor just said, oh, they're pregnant, we just can't give them these drugs. So even once they're approved, they're either the physician thinks they can't get the drug, they don't know the counseling, the patient is unsure, and you just see that this problem kind of perpetuates. So then we have to gather the data in pregnancy, but we can only gather it retrospectively, right? Meaning that, okay, some doctors like me start to use it, some others start to use it across the country, and then we try to piece it together in a super messy fashion. Like I said, I work with Gilead to publish the data on remdesivir in pregnancy, and we published it, but what's the critique? There's no control group, there's no safety data, there's no efficacy data. So we did gather the data for pregnancy, but then it's criticized as low quality, right? So this is what happens, and so that's why it's so important to get pregnant women involved up front. And the vaccine trials, which I kind of alluded to in the beginning, this cycle. So you could just press this cycle and press repeat. A lot of OBGYNs were hopeful, like, okay, certainly everybody saw what happened with therapeutics in pregnant women. It was a disaster, right? There were no studies in pregnant women. Certainly we're not going to repeat that with vaccines. And guess what? We repeated that with vaccines. Pregnant women were completely excluded from the trials. And this was a new vaccine. We know we give the flu vaccine in pregnancy. We know that, vaccines that are not live vaccines are probably safe. But this was a new technology, messenger RNA. So really there was that extra layer of concern. But what we saw is the vaccines were, as all of us know, superb, right? Superb. And if you look at the blue line was people who got the vaccine, and the red line was cases of COVID if you got placebo. But, right, so that's great, big difference. What's the first question that comes up? Can I give it to pregnant women? Not sure, no safety, no efficacy data. So it's the same exact bind, right? Can we give it? What about the risk to the fetus? What about breast milk? And it's so important because I can tell a patient there's this huge difference, but I just don't know. Now, we did obviously ultimately give it to patients, but who did we give it to, right? Healthcare providers. We give it to doctors, nurses, pharmacists, and they took it because they were so scared because they were seeing COVID firsthand. They knew how bad it was, and they saw this promising data. So actually, all those frontline healthcare workers that were pregnant, they actually took the leap for us and agreed to get these vaccines. And that's how we got most of our early data, was from this group who took a little bit of a leap of faith outside of a clinical trial, right? So the other part is they were outside of a clinical trial. There was actually less safety monitoring in their particular case. Luckily, we have a lot of great physicians around the world. Once the mRNA vaccines became available, the CDC was collecting the data. There's this V-Safe program, but it really relied on individuals kind of reporting the data. You sort of just by self-report, right? And then researchers, a lot of pregnancy researchers, this was like one group in some of my old colleagues in Boston, you know, but they're doing the work that should have been done in the clinical trials, right? So that's one. Two, in order to gather this data, they had to apply for NIH grants, meaning we wouldn't have found out this data unless these group of smart people they had to apply to NIH grants to do the studies that should have been done as part of the trials. So they're actually supplementing the trial, right, to gather and really basic stuff like, does the vaccine produce antibodies in pregnant women? Do these antibodies get into breast milk? Do they get into the cord blood for baby? These are things that should be sorted out in the trial. But fortunately, the pregnancy researchers are doing the work, but it's delayed, right? So we don't really have this data until at least 3 to 4 months, maybe more, after the vaccines are approved. So there's a huge delay from when non-pregnant adults get the information to when pregnant adults get the information. And that's a concern when we know that pregnant women are getting more sick. So, my experience, I obviously lived it firsthand, and I got very involved. I sought out, when pregnant women were getting sick, I sought out what clinical trials can we offer, and there were very little. So I did start using this compassionate use for remdesivir. I saw how cumbersome it was. We gave off-label medications, and I saw that there was no follow-up, no safety monitoring. And I knew that approach is not really effective. So actually, I did find a clinical trial with a drug that sort of repurposed, but I had experience with it from preeclampsia. And we actually launched the trial at Cedars-Sinai to treat pregnant women with severe COVID-19. My experience was that pregnant women and postpartum women had a strong desire to participate in clinical trials. They were able to give informed consent. When I explained the study, when I explained the rationale, they could make an informed decision. Like I said, there was nothing about pregnancy that impaired their ability to make these decisions. They knew what was at stake. They knew that their life was at stake. They know their baby's life is at stake. And they have to make that decision. Do I try this medication or not? And you can imagine many people knowing how bad COVID is and how sick that they felt, most want to be involved in clinical trials, and most of our patients were enrolled in clinical trials. So I'm very proud of that our patients were enrolled, but this wasn't available everywhere. When I talked to colleagues, the vast majority had no clinical trials to offer their pregnant women. So we have to bring down those barriers and say, how do we make this happen at a larger level, not just for COVID, but tons of new drugs on the horizon. And if we keep excluding pregnant women, just the gap in knowledge is just going to keep expanding. So thank you for your time. I definitely want to get to some questions and help that we can kind of help advocate and push for this, important topic.
Great. Thank you. So I'll start off with a couple questions. In one, and thank you for your wonderful presentation. So looking ahead, even though this is a once-in-a-century pandemic, with globalization and the reality of communication through the world, it's probably not going to be the first time this happens. Are there plans going forward for the next potential viral illness that comes to our shores, that we could potentially have an alternative approach so that we can do research early on that includes pregnant patients? And if so, is either ACOG or the federal government, NIH, involved in listening to your wisdom?
Yeah, that's a great question. And I think, ACOG and SMFM definitely seem to push and advocate and wrote, they wrote a lot of letters, of course, advocating for inclusion of pregnant women, and they made also a presentation on Capitol Hill, but something happened, right? I think a lot of those groups felt confident that they got the message out on the vaccine trials. I think they felt really confident that pregnant women were going to be included. So that was, that seems we have to like problem solve, like what went wrong there, like why did that not happen at that time. But right now, moving forward, also some of these companies like Moderna like want to use their technology to maybe revamp the influenza vaccine. They want to make an HIV vaccine, right? So we just can't. What if they do develop an HIV vaccine and it can't be offered to reproductive age women, right? So we have to say, when companies are developing these products that have potential huge ramifications, it's the company. Well, the company is always going to try to exclude pregnant women, but the FDA has to push back. The FDA has to say, no, that's not allowed, actually. We will not, because the FDA and the NIH is helping them out, right? The NIH and all these medical centers, the companies need the NIH, the companies need the FDA, the companies need institutions to run the trials. They can't run the trials by themselves. So, yes, a lot of people blame the companies, but the FDA, maybe it's like people worry about medical, legal. If you have time, you need to gather some reproductive safety feature, like in mouse models, and but with this kind of thing, yeah, you're right. You don't have the time to do the preclinical studies. So then you have to decide: how do we bypass the medical legal ramifications that the companies are worried about? And so that's multi-layered in terms of what can be done.
Well, the two things you could do is, one, mandate whenever a new drug or a new therapy is being developed that a small animal trial is done for safety purposes. So that's done preemptively on every single drug. Costs a little bit more on the front side of drug development, but it would be protective so that if there was an emergency like this, you'd be able to protect. The other thing is you can have emergency legislation that held them harmless, so they wouldn't have to worry about the liability and the problems that we would have, and the fears that that company would have for their market in the future.
And then there are plenty of labs, as we saw from the studies post-vaccine, tons of really great laboratories across the country that could maybe partner with the pharmaceutical companies to do these experiments in a more timely fashion. Because it's such a disconcerted effort. When you think about it, there's this huge race for NIH grants, and all these groups are reproducing the same studies, the same efforts, which is great. You have 5 or 6 groups or more doing the same studies, racing to be the first one to publish it, which is good. Part of that competition is good, but it's not efficient, and it's not the best use. We could, especially, you're right, a global pandemic like COVID. I don't know, but maybe this will be. You're right. We don't know. We have to say it is possible that this could happen. Every so often, and having a better approach to get in studies done a little bit more quickly.
And then a little bit of a tangent, but just given your expertise, we know that even chickenpox can be deadly in pregnancy, which is clearly not the case in other populations. But SARS and MERS were devastating with pregnant populations. Initially, the initial belief was that though there were unfortunately some people who were really critically ill, that we were doing a little bit better with COVID-19. At this point in time, what's the consensus belief on that?
Yeah, I think you're right. Fortunately, it definitely doesn't seem like it was as bad. Actually, even influenza had worse outcomes for pregnant women, particularly in other countries. But you're right, the COVID, fortunately, that would have been really, horrendous if it was as bad as those other ones, because, the original SARS and MERS were worse in terms of pregnancy outcomes. But it's amazing knowing that this was a pathogenic coronavirus and knowing that potential, it should have been all hands on deck for pregnancy. And maybe we got lulled into, the China data was not looking that bad for pregnancy. The Europe data was a little bit ahead of us. But we didn't know for sure. And I think, so that was, knowing the history of the virus. Luckily, I think you're right. It didn't turn out quite as bad for pregnancy. And it seems to be age is a big factor. So pregnant women are younger. But, it was, but still many women affected, more women probably impacted than needed to be.
Thank you for your wonderful presentation. Commissioner Khalfani, you have a question.
Yes, quick question. And I don't know if you all planned this on purpose. This is Black Maternal Health Week, so it's interesting to be having this presentation at the same time. I mean, and I really appreciate what you shared. So I'm also just curious, where is the research now, right? So when we think about, and I know that it's been an ongoing question in the field, like, okay, where's the data as it relates to pregnant women? And then it's like, now after the fact, where are we? But I'm just curious, has it increased in terms of research or including women, pregnant women after the fact, or just where are we in the research, if you have any sense of that?
My feeling is it's still not where it needs to be. There should somehow, because they're still not, the pregnant women are still not involved in these clinical trials, and there's still very little therapeutic data for pregnancy. Now, there's a lot about access to care, resources, because a lot of it, right, is getting into care. I think we could decrease a lot of the mortality by just getting patients into the hospital quickly, and maybe we funnel them into a tertiary care center. Like, at our institution, we did have a lot of COVID patients in early March of last year, and obviously there was a lot of debate of where should patients go in the surrounding area, and some of the ICUs just literally filled up. But when there's space, if we have these extra expertise and we have these trials, so like I was able to get 2 patients from another hospital brought in specifically for the research trial, but I've been personally advocating for why aren't we spreading the word to say, hey, I don't know if there's other pregnancy trials, or why can't I make it more known that we have this trial, and if you have a sick pregnant patient, they could come to Cedars to be treated. What are the barriers to making that happen? Is it insurance? Hopefully not, but I know on my end, I wanted to get that word out more to make it be known that we have a pregnancy trial. So there's little things like that. But I talked to many, many people that didn't have options of treatment, and the 2 transfers that we took from outside, they were on ECMO. They came in to get put on ECMO because they were so sick, and those patients had a really, really obviously prolonged course, and we can't get to that point. So other hospitals, if they don't have the drugs, they don't have, maybe they haven't had as many patients, the disease just kind of advances, and then when they transfer, it's at a point where it's just too far along. So I think maybe that's part of it is how do we sort of organize to sort of funnel patients into high acuity centers that have maybe the resources to be able to, especially, definitely at least for the sickest patients, to prioritize those cases.
And then the last question, you may not even be able to answer this, but you shared how healthcare staff, providers, they really were the testers. So you had those pregnant women getting vaccinated. So were there studies for any of those that were vaccinated that have now delivered with any understanding of, does anything get transferred to the baby in terms of antibodies? It's like, is there anything, I guess I could just Google, but it just made me think about that as you were sharing.
Yeah, and we haven't, I think Cedars is collecting it as well, and we haven't published our internal, but other groups have, now a couple groups in Boston, I think in Texas, in St. Louis, have published those exact things, that the vaccines produce antibodies, that the antibodies are getting into the breast milk, that the antibodies are getting into cord blood at delivery. Now the next step is, are those really protective? They suspect so. They look exactly like the type. They do the kind of things, like when they test them, it looks like those antibodies are doing the right thing. So that's coming out, but it's just the point that it takes so long. I'd probably say it's just really in the past month. So we started getting the vaccines in December, January, and now we're into April. So it does come out, but it just takes a bit longer. And the other part is, how did we wanted to prioritize pregnant women. This problem that we run into is, as soon as we have the vaccine, we want to prioritize pregnant women, but we have no data. So that was tricky. I think now that part of it is a little bit better. That now it's like getting the messaging out now that we're collecting this data, that the vaccine is safe and effective. Now you're right. Now it's a lot about messaging, because prevention is going to be much better than all these treatments. So I think we're doing good on that end, but there's still some way to go.
Thank you.
I know in Boston, where you spent some time training, the Massachusetts General Hospital ended up being a referral center where they were bringing patients in from all over western Massachusetts to the east and down from New Hampshire and Maine, so that they have larger numbers of patients so they can use their expertise, and so that worked pretty well there. I'm not so sure we didn't have the need as much here, because our numbers, in the early part of 2020 were not as bad, but it's something that, looking forward, this commission could potentially recommend to the city council and to the mayor that we have a system in place so that we can coordinate the care from the leading institutions that we do have, and specifically in pregnancy, with Cedars being one of the larger centers, or actually it is the largest center in the city of Los Angeles that delivers babies. You and Long Beach Memorial being the two largest in the county, potentially we could have a central focus so that we can concentrate the expertise that we have. It might be something for our commission to look into, to discuss, and maybe making a proposal. Clearly, in our report that we present to the City Council, that might be an area we can also suggest that going forward. Not just for viral illnesses, but just for central focus. I mean, Dr. Burke's an expert in HELP syndrome. Mortality of HELP used to be 90%. Now, with good care, we can actually save probably 60-75% of those patients if they get the good care. But unfortunately, in the city of Los Angeles and county of Los Angeles, that doesn't always happen. So there is more maternal mortality, and in regards to the Black population is even greater, and so that's an area where potentially going forward we can have a HELP program where people get focused, so that combining our first speaker, maybe telehealth, where the experts who know the most about HELP are advising every single hospital that finds a patient with HELP as an emergency call. We do telehealth so that we can have an expert, MFM, who's hand-holding the experts at the hospital, wherever they might be, a small hospital that's only delivering maybe 1,000 babies a year and doesn't see HELP that often. So potentially that's something else we could potentially put in our report or look into. Commissioner Lemus, you have a question.
Yeah, so first of all, thank you for such a great and informational presentation. What I'm trying to understand is there just a general consensus nationwide to leave pregnant women out of clinical trials? And the reason why I ask this is because looking at the Office for Human Research Protections, they don't see women listed there. So do just institutions across the nation then take it upon themselves just to leave out to leave women out of clinical trials? I'm trying to understand where the advocacy lies in terms of really being able to gain momentum around this. And so, I just went to IRB a year ago, so I don't remember seeing pregnant women. So, it was surprising to me to learn all of this. So I just wanted to learn more about that.
Yeah, I mean, a lot of it is, it does start from the companies in terms of, they don't have a lot of motivation sometimes, or a lot of incentive to include pregnant women. They get from their end when they have these drugs and they want to test out their new drug. They feel like it's taken on risk, right? If anything happens, a lot of it is medical legal, and so I think that's why it's on the other end to say, that's some contingencies that we're going to say, okay, in an emergency, in these life-threatening situations, that maybe, that there's some liability coverage for things that we say, no, you can't, so that way we can say, no, you can't exclude pregnant women. Part of it, yeah, we need OBGYNs to have a seat at the table. I know a lot of people high up in our societies feel like there's not enough people advocating for pregnant women and postpartum women. I think more so, obviously I'm biased, that's the community I'm around. They seem like they're passionate, on social media and everything. They're constantly advocating, for pregnant, and breastfeeding women, but it hasn't translated yet. But I think this magnified it. COVID, good or bad, really magnified a lot of these disparities, right? Not just pregnant women, but the disparities in our system on every level were magnified and made more clear. So hopefully that will be remedied.
So I think also following up on that, the two biggest areas is the liability issue. That you need to identify the companies who are doing research on pregnant women or women who could become pregnant. The other problem is a little bit more complex and more political, which is the Hyde Amendment, which is that the funding for a lot of federal research is coming from NIH or the NCI. And what would happen if a baby was being developed and had multiple congenital abnormalities that would not lead to a life that was long-lasting and or a life that was, critically devastated. Current law doesn't allow federal funding to pay for that termination of pregnancy. So it's a political landmine, which I think is one of the reasons that Capitol Hill hasn't touched it. And there has been times of discussion of protecting the pharmaceutical manufacturers and or, in the case of COVID vaccine, giving them liability protection or clinical trial liability protection. And that kind of died on Capitol Hill. So I think that it's even more complex when you talk about pregnant women. That clearly that's something that the Congress has to deal with. I think that's above law pay grade right now. Though I think Commissioner Lee, your question is a good question. Just unfortunately, it's something we can't really deal with. But we can. I think with compassionate use is something that can be fast tracked clearly. And I'm not sure about liability protection, but liability is usually state run. So that's something that actually Sacramento could deal with independently. So we could potentially have our legislators advocate to Sacramento to have emergency use, compassionate use in certain circumstances, so that if there's another situation that happens in the future, or if there's a fifth wave that comes, that we could be ahead of the curve. So I think that's a good thing. Any other commissioners have questions? Seeing none, Dr. Burke, was wonderful that you would come to us. I'm honored that you take time. Please feel free to reach out to us if there's a way that we, as a commission, can help you do research and or work with the City of Los Angeles. And additionally, I do think that you brought up some good points that potentially we could address and we could advocate on behalf of women and specifically pregnant women who need therapy to the City Council, so that potentially we can get you some help going forward. And we'll probably have our research associates contact you, and I know you've been in contact with them already to follow up and potentially so that when we write our report that we're properly quoting you, and if there's data that can support things, that we can have that data included in our report. But we're honored that you take time. We know how busy you are. Thank you for your service to pregnant women in the City of Los Angeles. We truly appreciate your coming to us today. Thank you very much.
Thank you. I appreciate it. Thank you, Dr. Magna. Thank you to the whole commission and great questions. And I really enjoyed this conversation and would love to keep working with you and advancing this cause.
Thank you.
Thank you so much.
Any other? Any other items for discussion for today?
The last item on the agenda are items for future discussion.
Correct, exactly, yeah.
Thank you.
Seeing none of the commissioners have something to bring up, please know that you can always reach out to the research associates and our interns, and they will help you develop things. If you have ideas, please send them our way. We look forward to the May meeting, and if there's something that you wanted to be fast-tracked or prioritized in discussion, please let us know. Seeing no other questions from the commissioners, can I have a motion for adjournment, please?
This is John. I'll make a motion. John Hesser. Make a motion.
Thank you.
To adjourn.
Second?
I'll second.
Thank you, Commissioner Vice President Grimmick. Any other comments? Seeing none, all in favor of adjournment?
Aye.
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 Any opposed or abstaining? Seeing none, we're adjourned. Thank you, Erica, for your efforts. Thank you, Albert. Thank you to our research associates, Lauren and Sarah and Marvin. I think you're out there someplace. We truly appreciate all you do for the city of Los Angeles, and thank you for the city for allowing us the chance to having this meeting. And thank you again to Drs. Anaya and Berwick. We're really blessed to have two leading experts in Los Angeles that we can call upon to help us. Thank you very much, everybody. Be safe. Wear your mask if you're in a public place. Get vaccinated. We're now open to have everybody vaccinated. If you haven't been vaccinated, please be vaccinated. The first one you can get. Don't worry about which one it is. They're all that are approved by the FDA, have great efficacy, and we want you all to be safe and healthy. Thank you. We're adjourned.
Take care.
Bye-bye. Thank you.
Bye-bye.
Thank you.
Good deal. Thank you, Erica. You're great.
Thank you very much.